Okay, it looks like we're holding steady, so I think we'll go ahead and get started. So thank you again, everyone, for joining us this afternoon. We here at TACA are super excited for our first resiliency workshop and to have a guest like Dr. Robert Haley with us today. I'm going to tell you a little bit more about him in a minute, but first I'm going to hit just a couple of housekeeping items to get us started. So first and foremost, this workshop is the very first session of TACA's Resiliency Initiative, which was just announced here in Dallas yesterday. TACA created the Resiliency Initiative to support and strengthen the Dallas arts community in response to COVID-19 and the effect of the pandemic, the relatively severe impact of the pandemic on our local community. So the initiative includes multiple grant-making programs, capacity building workshops, which are essentially our amplifier workshops transitioned into this resiliency series, of which this is the first session, and other thought leadership initiatives to help ensure that Dallas and our arts community survives and continues to thrive. So if you haven't heard much about it, we encourage you to go to taca-arts.org/resiliency and learn more. Today's session is a result of a suggestion that was actually made at our most recent virtual meeting with grantees in June. So we sincerely hope that the dialogue we have today with Dr. Haley will help provide critical facts and guidance to you all as you work on public reopening plans and strategies. For flow for today, we're going to start with a presentation from Dr. Haley that will cover, as he calls them, the facts about COVID-19 and what that means for arts, art making, and our audiences. There's going to be time for questions after the main body of the presentation, so just use the Q&A function at the bottom of your screen to send us those questions. The second section will be our reopening masterclass, which is going to feature Mara Richards-Bim of Cry Havoc Theater Company, Megan Heber of Children's Chorus of Greater Dallas, and Gail Halperin of Brucewood Dance. Each of them are going to present their current reopening plans and safety protocols, and Dr. Haley is going to provide feedback to them on those plans on this webinar. So we hope this will help inform the plans that we know all of you are working on diligently, and that this information and that reopening masterclass, as we're calling it, will be helpful. You can also submit questions during that section. Just use the Q&A function at the bottom, just like you did at the start. I want to say thank you to Communities Foundation of Texas for their support of TACA's capacity building programs. I want to do a shout out, even though I don't think she's on, to TACA board member Sarah Cotton Nelson, who connected us to Dr. Haley. An enormous thanks to Dr. Haley for his time and expertise that he's so generously sharing with us today. And of course, thanks to our 3 masterclass participants, Maura, Megan, and Gail. So, our esteemed guest today is Dr. Robert Haley, Professor of Internal Medicine and Director of the Division of Epidemiology in the Internal Medicine Department at UT Southwestern Medical Center here in Dallas. He's actually the founder of the Division of Epidemiology and Preventative Medicine, which I think is a fun fact. Dr. Haley spent 10 years of his career at the CDC, and he currently serves as a member of the Dallas County Public Health Advisory Committee for the COVID-19 response. He's a Dallas native, a passionate art supporter and patron. Both of his parents were actually classical musicians, as was he in his youth, and he now encourages the same love of the arts in his grandchildren. So, without further ado, Dr. Haley, the floor is yours.
Okay, well, thank you so much, and let's get to it. As far as I know, this is the first time anything like this has been done, maybe anywhere, certainly in my experience. So we will give it a try here and see how we can do. And I hope that what I really hope we do here is by getting more basic information about this problem out to everybody. How does this virus work and how can we defeat it? By knowing these basic facts about it, that this will stimulate you in the arts who are developing programs in the arts to come up with clever, original ideas that can open up the arts in Dallas, but safely. And I really believe there are a number of things we can do to make this a lot safer as we go into the future. Okay, so let's let me rearrange here a little bit, and let's see. Let me share my screen. Okay. Okay, can everybody see my screen there? Okay, good. Okay, so I call this COVID-19 pandemic of the century, which literally it is. This is the big one, at least so far. What do we know and what do we do? Okay, and I'm going to talk about the origins of the problem. I'm going to give you a current update first, then the origins of the problem. The pathogenesis means how does the virus work and infect you? The clinical presentation, what are the symptoms and so forth. How do we do surveillance so we know what's going on? What are the treatments? And there's not a lot here. But what are the preventions? That's the really thing we're going to be focusing on. So then I'm going to give you one slide at the end of this part here that gives you what I think are the 8 things that if you can build these in to the extent you can build the most of them in, the safer you make your activity. Okay, so first of all, a little update. This is as of this morning. The world has seen 15 million cases, but it's probably 10 times that in terms of cases, and 600,000 deaths. Maybe twice that is real. The USA, almost 4 million. We will pass 4 million probably by the end of this week of total cases, 142,000 deaths. In Texas, we've had 341,000 cases and 4,000 deaths. And in Dallas, 39,000 cases, 500 deaths so far. Now, that's the same information. I want to compare this to our annual influenza, you know, what we call the seasonal flu. Every winter when you get, now influenza is not just a common cold, it's a really bad cold. It's one with high fever and severe aches and just a cough that doesn't go away for a while. That kills between 10,000 and 40,000 people a year. A lot of people don't realize that, but we've already had, in the same time we might have lost as many as 40,000 deaths in this country. We've got already 140,000 deaths in this country already from COVID. So when somebody says this is just the flu, that is wrong. This is a much more deadly virus, and it is even more transmissible than the flu. So it's more contagious. In Texas, we've had, as you can see, we've had 4,000, which is more than the flu deaths we have per year. Now notice though, if only 5% of our population has been infected so far, and that's what we estimate, only about 5% of people have gotten it. What if you multiply these numbers times 20? You can see we're looking at a colossal catastrophe if we just let this thing go. So that's not an option. Okay, here is what we call the epidemic curve. This is the number of new cases of COVID-19 in Dallas County per day since the beginning in mid-March. You see we had an increase and then it leveled out, and then after Easter holiday, we had another big increase up to a plateau. And then when we really opened the state's economy in this zone here, we then had a slow keep creeping up, and after Memorial Day, the young people got the message that we've opened up, so it's business as usual, back to business and fun as usual. They started going to the bars and social events and parties and big family gatherings without masks, without being careful, and what we had was a spiraling upward, and finally an explosion here in late June, around the 1st of July, and at that moment, the governor finally relented and put his mandatory masking, statewide masking order in place on July the 3rd, and just before the July 4th holiday. And you see that stopped this dramatic increase, stopped it dead, but it just leveled out, okay? But remember, the time course of events. When we have a major change like this, it takes 2 weeks for the effects of this change to be seen because the incubation period of the disease is 2 weeks. So on July the 3rd, here, when he passed this order, we were seeing cases that were caused 2 weeks earlier back here, you see. So, we had an immediate leveling off, which was very optimistic to me. A lot of people were disappointed, but we were seeing over 1,000 cases a day. But as of yesterday, for the first time, we saw a measurable decrease. Went down to 870 cases, I believe, yesterday. And we hope that it's going to keep going down and that we may actually see a dramatic drop. I'm predicting this, although cautiously, that this mask in place order may actually do it, because I think the great majority of people are following this, and only the diehard skeptics are holding out and trying not to mask, but they're being pretty much forced by businesses and their friends and so forth. So I'm optimistic this is going to come down. But as we'll talk about in a little bit, this is an absolute requirement for us to go back as business, any kind of business as usual. Okay, so, but it looks like we may be on the trail of actually making that happen. This is the number of deaths, and you can see a slow, kind of relentless upswing. The big jump here is on Monday when weekend cases get reported. So where did this virus come from? Well, it arose in China. There are rumors of elsewhere, but that's not right. It arose in China. You see it crept along with a few cases, and then in January, it started going up and just escalated and dramatically increased. This is in Wuhan, mostly Wuhan City and Hubei province, where it worked. This is the rest of China and the provinces around it. This is Hubei province, and Wuhan's right in the middle of that. And the rest of these are this curve here. But notice, between January, late January and late February, they controlled it. Look at that. Went down to a small level, and then it went down to almost nothing. How did they do that? Well, they closed their economy just the way we did, but they required universal masking. And that is going to be the thing I want to drum into you. Masking is the key. Now, there are other things we need to do along with it, but masking is a key. So they practiced social distancing, they closed the economy, everybody masked. But see, in China, in the Far East, they've been doing this for 30, 40, 50 years. Everybody, when they get a cold, everybody wears a mask out on the street. You see people on the street wearing a mask. So they're used to doing that. And they saw SARS back in 2003, which was a devastating thing. So they've been through this a number of times, and they knew, they were trained, everybody wear a mask, and they're still doing it. So that's how they did it. Very important. Here shows you the spread. Now, this is the map of spread of this virus. And this is a fascinating way how this was done, but it's with genetic technology. But every 2 weeks, I've got a new map. And you see it started in China. It got bigger, started spreading, went to the United States. And then in early February, it just went crazy in China. But between 1st and the 15th, they started controlling it. See there? But by that time, it had already spread the United States, and it started growing here. We started exporting it back. We and Europe began exporting it. Then China is now almost closed it down, but now the countries around it are growing, and the U.S. is becoming the major exporter of this product. Between March 15th then and April 1st, we go completely crazy, okay? But then we started the orders to stay in place, to shelter in place orders and shut down our economy, and it started going down, you see, and then it's going down all over the world and no longer spreading so much. This is kind of a representation of how big the various epidemics were in the various countries, and you can see we take the cake, and it's because we did not mask. We did not have the leadership and the follow through of our population, the complete buy-in of everybody to mask. I think we are getting close to getting over that now, but that's the key. Where did it come from? All these viruses began in either bats or rodents. Okay, that's where they arose. There are 4 coronaviruses that cause the common cold. These have been around for over 100 years. They keep coming back, which makes us a little worried about COVID here. But that accounts for about a quarter of all common colds. Then we had SARS in 2003, which had a 10% mortality rate. The common colds don't kill people, but the 10% mortality rate, but there were only 700 cases in the world. And it was eradicated quickly in this country as well as every other country because we got on top of it. We had a test for it very quickly, applied the test, quarantined people, and it went away. We could have done it with this, but we didn't get organized in time, and you know the story there. MERS, the Middle East Respiratory Syndrome, arose in bats, transferred to camels, and then to humans. 40% mortality. This is very dangerous, but it's been pretty much controlled around the world too. COVID-19 came along here. It's about only a 1 to 2% mortality rate, but given how rapidly it spreads, more rapidly than these, we got a lot of deaths quickly. So basically what happens is the virus has been evolved in rats or bats, but it has to go, they can't infect humans, so it has to go through a middle species here, llamas, cows, civet cats, camels, and we're not sure of what the COVID went through, but it went through something, a pangolin or some other animal in the Far East, and then it spread in humans. Okay, that's how it was. This is to show you, this is the genome of the virus, and here are all the mutations that have occurred since we saw it in China from the beginning. So the thing is constantly mutating, but it's mutating at a very slow rate compared to influenza. Flu mutates rapidly, and that's why we have to have a new virus every year. But for COVID, it's pretty slow, so we're not going to, if we can get a successful, safe, effective vaccine, it'll probably last for years without mutation bothering us. Okay, how does it affect you? Okay, very simply, the virus comes, here's your lung cell, okay, here or here. And the virus comes along, you breathe it in, it attaches to the surface of the cell and then gets inside the cell, and then it opens up, letting its RNA loose, and then the genome of this virus has a gene that codes for this thing called the RNA-dependent RNA polymerase, or the RDRP, which is basically a little machine that duplicates, it's a little copy machine that duplicates its strand of RNA many, many times and spits those out, and each one forms a new virus which exits from the cell. And then you get hundreds of viruses coming out of this cell that go infect other cells. So the treatments are aimed mainly at trying to stop RDRP, this little copy machine, to stop it. And some of them look like they might work. How does it get into cells? That's really the key. It comes along here on your lung cells. You have a little thing called the ACE2 receptor. The ACE2 receptor is a little protein on the surface of your lung cells. It's there. It's got a good purpose. It helps control blood pressure, interestingly. But the SARS-CoV virus can attach to it one of these little spines on the outside, little spikes. They will attach to that ACE2 receptor, and that allows it to get inside the cell. It turns out not everybody has these ACE2 receptors. I'll show you in a minute. And so one of the vaccines are going to be aimed at neutralizing this spike protein. Most of them are. And if you can neutralize that, then they can't get in your cells. Pretty clever. This is a graph that just was published a couple of weeks ago. This is the number of ACE2 receptors you have on your cells. And this is age. You see from 25 up to 60, you got lots of them. 18 to 24, lots of them. 10 to 17, not quite so many, but less than 10 or less, you have very few. And that's why little children, 10 or less, don't really get this disease much and very rarely have serious effects. And teenagers get it and can pass it on some, not as much as adults, I don't think, but they don't get really sick with it. Okay. All right, clinical presentation. how sick you get and where you get sick is determined by where those ACE2 receptors are distributed, mostly in the lung. That's why this is mainly a lung disease. But they're also in the heart, and some people can get heart problems with it. They're in the intestinal tract, so you can get diarrhea, abdominal pain, and so forth. In the kidney, you can have kidney problems. And in the testes, we don't see any problem with that so far. And in the blood vessels, the arteries and veins, including those that go up into the brain. The brain doesn't get infected, but the arteries and veins can. So you can have, so the infection, the symptoms are these, but nobody gets all of these. In fact, no symptom occurs in everybody. So this thing is very elusive. So the rule is during an epidemic, if you've been exposed, if you get any of these, then you go get tested. So it can be fever, fatigue, muscle aches, cough, chest discomfort, abdominal pain, diarrhea, and vomiting. Sore throat is actually fairly uncommon. Stuffy nose may not occur at all. I'm not sure, but we haven't seen it. Elderly may present without any of these. Your elderly people in nursing homes may just get real sleepy, become disoriented, or just stop talking, and that might be the only sign they have it. You can get coagulation or clotting defects, deep vein thrombosis, blood clots in your legs, traveling blood clots into your lungs, stroke, heart attacks, peripheral veins or arteries occluded, and these are fairly uncommon, but we treat for this in the ICU routinely to prevent, because this mainly occurs in the really severe cases. Cardiac problems, people can have heart attacks or whatever. And most interesting, the sudden loss of taste or smell. This doesn't occur in everybody. About half of people who get COVID get sudden loss of taste or smell. It's actually the sudden loss of smell, and that, most of your taste is what you smell. So, and it turns out that although this only happens about 50%, if this happens, you have COVID today. This is the most reliable sign that you have the illness, and you need to immediately go get tested and quarantine yourself. But of all these things, you got to remember, 50% of people who get this infection and can spread it to others never have symptoms. Okay? That's really important to realize. There are people walking around right now in this country, in this city, and maybe in your office or at home, who have the infection, can pass it to you, but they don't know it, and they don't feel sick at all. Okay? Now, a little bit more about that in a second. Here is the age distribution of cases, hospitalizations, and deaths. So here's 0 to 17, 18 to 40, 41 to 64, and 60 greater than 65. What I want to, so this adds to 100%. So the number of cases, 6% of the number of cases are in children, 39% in young adults, 42% in older adults, and 13% in elderly people. But look what happens to elderly people as we go from just having the illness to having so sick that you have to go to the hospital. 13%, now they're 34% of the sick ones, and they're 67% of those who die. So you see, something about being in this age group makes you really susceptible to getting a bad case. But that doesn't mean we don't get younger people. People 40 to 60 are a quarter of the cases. So you don't want to be in this group either. Now, young adults are mostly getting away with it, but although they can get very sick in the ICU, but they almost always survive. Men get worse than women. They're 54% of cases, 57% of hospitalizations, 66% of deaths. Okay, diabetics, hypertensives, and some other things predispose you also. Now here is the time course of the illness. Here's the day of your illness. So here's your first day that you get sick, okay, and here's 12 days later. All right, typically what happens is when you first get sick, the first symptom you have, at that moment, you have the highest amount of virus that you're going to have. And you have had it for at least 2 or 3 days before that. So for the 2 or 3 days before you know you have it, you are highly infectious to others. just like many other people who never get symptoms, okay? That's really important to understand. 2 or 3 days before you break out with symptoms, you are highly infectious. You remain highly infectious for 2 or 3 days, and then the amount of virus dramatically drops, okay? The amount of virus in the lung takes longer, but that's, we think it's actually gone away, but you get the dead bodies of these viruses being excreted out, and so you can, our test, the PCR test detects those dead bodies and can't distinguish dead bodies from live bodies. So we think most people are no longer infectious after about 3 days of illness, but we're not completely sure, so we don't bank on that. But anyway, it's probably true. The course of the illness is, it starts off mild. This almost always starts off with just mild, maybe fever, maybe not, maybe it's usually a cough, or it could just be diarrhea or something like that. It's very mild. You think, oh man, I'm gonna beat this. And then it gets worse and worse and worse. And finally on about the 4th or 5th day, it gets really bad. Some people, it goes away by then, but particularly in young people, but it gets really bad. But then you start getting well, and by the 9th or 10th day, you're pretty much over it, although you may have lingering fatigue and a little bit of a cough for a long time. However, for a few people, about 15% of people, on about the 7th day, you suddenly get a lot worse. And then about the 10th day, you get a lot worse. You have trouble breathing, you're not getting enough oxygen. And here you go to the ICU about this time, and then you get really bad and they intubate you here, put a lung tube in, put you on a ventilator. And then you have this catastrophe called a cytokine storm, because this is caused by your immune system going wild. Your immune system woke up to try to kill the infection. It may do that, but something about this disease makes it where your immune system does not stop. It keeps revving up faster and faster until it finally kills you. And that's what kills about half of people. The other half, just we can't get enough oxygen into them. But so that's the course of the illness. Okay, so we have an infection period here, then we have an unrestrained immune response to those who are going to get worse. But about 85% of people don't, and that's of the symptomatic. And remember, about really half of everybody who gets it doesn't even get sick. And of the other half that does get sick, 85% of them get well eventually. Okay, all right. Late complications, and mostly in people who don't even get sick, just show up with this called COVID toe. There's an epidemic in Europe and New York, and we're starting to see some around here now. This is a very sore toe. It can be one little patch, or it can be 2 or 3 toes, or like this one, all the toes. It's a real inflammatory, very sore thing. It's hard to walk, and there's not much you can do about it, just to know that it's COVID, but it's your immune system doing this, so it means you're over the virus. So it's a good sign, but it's hard to take. Here's a late thing in children that usually aren't sick, haven't been sick in about 6 or 8 weeks after they were exposed, so they probably had the virus and gotten well. They get this immune response, high fever and a bad abdominal pain. So if your child suddenly wakes up one morning just screaming with severe abdominal pain and high fever, that's not just a little tummy ache. That could be COVID right now. It's called the multi-system inflammatory syndrome in children. It's not the virus. They're over the virus, but it's their immune system, and it can do all kinds of things. Give them a rash on the hands, palms, and soles of the feet, and on the skin. Can give them a red eye, swollen lymph nodes, and so forth. It has killed 2 children that we know of in Europe, but that was early on before anybody recognized it. If the parents are alert, call the pediatrician. They can put them on steroids or some other medicines, and it melts away quickly, and it's innocent. It gets well completely. So this is not something that's going to kill your child, assuming you alert and call the pediatrician. Even so, it would probably get well most of the time on its own. Okay, surveillance. How do we find out? You've heard of this thing called the reproduction number, the R0, okay? This is basically the number of other people that will be infected by each case. So let's say we have a case right here, here's one person who's got COVID. If they infect only one other person, the R naught of this disease is 1. If they infect 2 people, if each case on average affects 2 people, it's an R naught of 2, and so forth. If here's measles, each case affects about 15 others, so the R naught's 15. So here's measles, chicken pox, rubella, German measles and smallpox, polio, HIV/AIDS, SARS-CoV-1, that was the original SARS, SARS-CoV-2, which is the current one, Ebola. See, this is more contagious than Ebola, MERS, and so you see, comparatively speaking, this is a fairly infectious virus. Okay, and this is over time. When the epidemic started, this was Texas. We were at about 3.5. Okay, and then we forced it down with our control measures, and it went below 1. Here's the deal: if the R naught levels out at 1, then the epidemic is not going to grow because every person infects one other, so it'll just stay the same. If it's greater than 1, okay, then the epidemic will grow. If we can force it down below 1, the epidemic will decline. And face masks, distancing, all of our control measures are efforts to force this down below 1, so each case infects less than 1 person, and then over time the epidemic will decline and go away. Okay, this is just an interesting study that was done, and they found that loss of sense of smell was by far the most discriminating symptom. If you see that, that's it. You've got it. Skipping meals, in other words, completely losing your appetite, and severe fatigue are fairly diagnostic, but nothing else occurs more often in this disease than elsewhere. So they're not so good as diagnosis, but loss of sense and smell is. All right, now testing. Basically, we have the PCR test that detects the presence of the virus. Okay, and we've got a bunch of FDA-approved tests that are being run by the major laboratories. They take 24 to 48 hours, although the new generation that just came out can be done in about 4 hours. Okay, and those are very accurate, very sensitive. They pick it up if it's there, and they're negative if it's not there. The rapid test, which takes 5 or 10 minutes, is great if you've got symptoms. It'll confirm that they're due to the virus. But if you don't have symptoms, they're no good at all. Right now, what's out now. Okay, so it's good to get the rapid test if you're sick, but if you're not, I wouldn't get that. There's over 100 non-approved ones of these. The FDA had a weak spell a little while ago and let a whole bunch of Chinese tests in that are no good. And so if you get one, a rapid test, at least ask, is it FDA approved? Okay. Now we're right around the corner. Later this year, we're going to get, it looks like, these home tests that you can do yourself. It's like a pregnancy test. You could do one every day. You could do 2 a week if you want to. They're going to probably cost about $3. That's what I was just hearing this morning on NPR. I don't know how good these are, but they say it's not very good, but it'll detect you if you have a lot of virus. So if you are infective, it'll probably detect you, but it wouldn't detect you early on. Okay, but now there's supposed to be ones that are going to be very accurate home tests that will be early next year, perhaps. And again, if they're well priced, $1 to $3, you could probably do them fairly often. And this may be where we end up a year from now. The antibody test, you've heard about the antibody test. That's not very useful, really. And I wouldn't recommend that you get this. You want to know whether you've got the virus. That's what determines whether you're infective, whether you're going to get sick. This determines whether you've had it in the past, but we're not sure how long these antibodies last. So this may wane after 2 or 3 months. We're not sure. So the tests are out there. You can get them, but I just wouldn't recommend this. There's no point in it. Okay, testing to identify cases. Here's one of our mainstays from public health department standpoint to eradicate this disease. If we can get the number of cases down to a low level by universal masking, okay, and by distancing, that's what's going to drive the epidemic down. If we get it down to a smaller level, then we'll have enough resources to identify every case, call their contacts, ask them, who have they been spent more than 15 minutes face-to-face with in the last 2 or 3 days before you got sick, because that's when you were infective. See, who were you with face-to-face for about 15 minutes or more? Okay, and then we want to call them, the health department will call them or send them a text or something, okay? Give them advice about how to quarantine themselves for 14 days so they don't infect others, because they may infect others when they're asymptomatic, see? So they need to be careful not to be, and to wear a mask and be very careful, to monitor their fever and their symptoms, but stay at home. If they get sick, they need to get tested. And if they get real sick, they need to go to see their doctor or to the hospital, but call ahead before you, don't just show up. Protect the hospital employees by calling ahead. Okay, so those are the deal. That's how we can snuff this thing out, by stopping this thing. You know, each person infecting others, we can find out all their contacts before they get sick. We can interrupt these cycles that go on. Treatments, there are non-pharmacologic, non-drug related, and then drug related treats. The main treatment right now is our ICUs have suddenly gotten really good at treating this. That's amazing. The Parkland ICU, which is kind of the best anywhere, although we got our other main hospitals are very good too, but Parkland's kind of sets the standard. 75% mortality rate if you went in the ICU before we started getting it here in Dallas. So the early experience all over the world was about you only had about a 25% chance of living if you had to go to the ICU. Parkland's got this down to 25%. We can save 3/4 of people now, and it's by really skilled nursing and overseen by doctors, but the nursing staff is really critical. They found that they can turn patients on their stomach, we call proning, prone positioning, and about at least 12 hours a day, on and off. And this makes them oxygenate a lot better than lying on their back or their side. Very interesting. To intubate them, to put them on a respirator as late as possible, wait as long as possible, and use high flow oxygen to tide them over, plus proning, and then use anticoagulant, blood thinner medicine from the very beginning to prevent the blood clotting things. And by doing that, we can save 3/4 of people in the ICU, but of course that's not good enough. Okay, so drugs, let me just quickly skip over this. There are no miracle drugs yet. You've heard about remdesivir. Yeah, it shortens your ICU stay if you're going to survive, but it doesn't affect your mortality that we know of. So big deal. That's not very good. Hydroxychloroquine, we don't have any clinical trials yet. All the stuff you're hearing about it is just hearsay, garbage from poor studies that don't make any difference. This might work great, it might work poorly, but we're waiting for our good clinical trials, and there are about 50 in progress, so we're going to get them eventually. Okay, so basically don't depend on drugs to save you with this. It's not going to happen yet, but it may in the future. How about vaccines? Okay, we do not have a vaccine yet. However, there are 140 candidate vaccines under development around the world. This is amazing. This has never happened before. However, let me warn you, most vaccines in the past have taken 10 to 40 years to develop, okay? The most rapidly we've ever developed a vaccine is 4 years. So, however, we've got some advantages. One, we've got 140 groups trying, which is new. We also have new technology. There are at least 5 major technologies that we could use to develop a vaccine. 4 of these are new and are being tried for the first time and are starting to pay off, it appears. We now have one vaccine from Oxford, from England, with American partners, that is now already gone through phase 1 and phase 2 trials, and now they're in a phase 3 trial with 20 or 30,000 people to show that they've shown that it's safe. In phase 1, we showed that it causes immunity to build up, but the proof of the pudding is and that's in hundreds or 1,000 or more. But now they're doing it in 30,000 or so during the epidemic to see if it actually prevents the disease. And that's the proof of the pudding. We've had a lot of vaccines in the past that pass phase 1 and 2, but just don't prevent the disease. For example, a whole host of HIV vaccines that have never done it. Breast cancer vaccine has never worked, okay, even though they got to phase 3. Okay, so we don't have it yet. The main thing here is do not count on a drug or a vaccine to save us. We do not have those now. We are not assured we're ever going to have them, but we might. It's very promising. But for right now, we need to protect ourselves, prevent millions of people from dying by tried and true public health measures, most of which we learned in the 1918 Spanish flu that broke out during World War I that you've heard about, that killed 50 million people in the world. Okay, we learned about masking and all of our other public health measures, and we've rediscovered them now over the last 6 months. So now, once you get over it, the disease, or get immunized, does that protect you? And we're not sure. I'm not going to go into this, but we're not sure if it protects you or not. I kind of suspect that it will, but remember there are those 4 coronaviruses that can cause the common cold. So those keep coming back every few years, and the same people can get them again, but I'm not sure they get as sick the second time. So I think I'm pretty confident that if we get a vaccine, that it will really solve this problem, but we'll see. Okay, personal protective practices, a cloth mask, except when you're alone or with family or outdoors social distancing. Okay, so cloth masks. Numerous studies show that it works. Okay, you can own several masks and rotate them. All you got to do is leave one off for 3 or 4 days before you come back to it. You know, put them in order, you know, and take the next one and put that one back at the end of the day at the end of the line and work its way up. If you do that, see, even if the virus contaminates your mask, it goes away, it dies in probably a day or 2, and certainly by 4 days it would certainly. This virus stays alive much longer on hard, shiny surfaces like tabletops, doorknobs, things like that. It doesn't survive as well on fabrics. Okay, so a mask is probably safe after a day of 24 hours of non-use. Masking is a key to restoring our arts and our economy. Okay, if everybody would mask, this epidemic would be driven down to nothing, and we could all go back to work with masks. We may be wearing masks the rest of our lives. I hope not, but we might, but we got to get used to it. All you got to do is get used to it. It's not bad after you get used to it. Ask any doctor or nurse. Maintain physical distancing, 6 feet, actually 3 feet may be just as good. There's evidence coming out that may be just as good, but right now the recommendation is 6 feet. Avoid touching shiny surfaces particularly, but anything. Clean hands with soap and water or alcohol-based hand sanitizer. Avoid touching your face. When not masked, cover your coughs or sneezes in an elbow, but this shouldn't happen. You should always be masked if you're around people. If you're exposed to somebody else who has it, self-quarantine for 14 days. That means don't go to work. Now that's a tough pill to take, but that means try not to be near somebody who's a case. Okay, so all your friends need to be masking, and then you won't be near somebody with a case. If you get ill, get tested and self-isolate at least till 3 days after your symptoms go away. Okay, after your fever goes away. Okay, now masking. What happens is when you speak out loud, you speak, you yell, you sing, you sneeze or cough, you spray droplets of different sizes out. And if somebody is not masked around you, they inhale these into your lungs, and that's where you can get a fatal case of it. Masking the bystander protects the bystander. At least at first we thought it didn't protect the bystander, but it turns out even a cloth mask is very protective of the bystander. I'll show you in a second. So if both are masked, then everybody's really protected. okay? Let's see. If everybody masked, 80% of people masked, this would stop the epidemic. This is what 12 Asian countries where they all masked, 98% compliance, it went away in a month. Universal masking is recommended by everybody. 24 states are now requiring it, including Texas. 75% of Americans in surveys say they comply. Only masking can open up the economy, okay? Here are the states that the green is the ones who have statewide masking. Only 2 states have nothing. The yellows have voluntary masking, but that doesn't work. Here is, very quickly, this is what happened in the 15 states that passed the first mask, statewide mandatory mask order. Look what happened. Over the first 25 days, they've been rocking along. Here's their COVID rate, and it just started plummeting. See, this was in the 15 states that first masked. Here are the rest of the states that had voluntary masking recommendations. Which state would you rather be in? Let me remind you, here's what happened in Dallas. We had a statewide masking order, and suddenly this geometric increase, free fall, if you want, this was going to infect everybody. Suddenly it cut it off. Okay, it now has stayed level, and now 2 weeks later, we may be starting to go down. So I think we're going to recapitulate what every other state that's done this has done it. Here's a quick experiment. Let me quickly talk about, because this just came out last week, and to me is the most convincing evidence about masking. This is an experiment that was recently done in Hong Kong, at the Queen Mary Hospital in Hong Kong. It's a very great medical school. They have this isolation unit here, and inside there they have these cages of guinea pigs, okay? And then here are some cages, and then here's a barrier here that air can go through, but the guinea pigs can't get by to touch other guinea pigs, all right? So you have 3 experiments, 1, 2, and 3. And what you have is, here are the sick guinea pigs that have been infected by a virus purposefully by spraying in their nose. So these guinea pigs get sick with COVID, and the guinea pigs really get sick with it just like humans do. Here's the next cage with 3 guinea pigs that aren't infected, and then the airflow goes this way so that it blows into the uninfected guinea pigs and tries to infect them. And in this one, there's nothing in between to protect them. Here, they put a mask on this cage, the infecting cage, as if you put a mask on everybody who's infected, you know, and to see how many of the guinea pigs get sick when these people have a regular surgical mask on. And here, they put a mask on the cage of the well guinea pigs to see if that protected them, you see, protected the mask wearer. And it turned out 6 of these 8 guinea pigs here got very sick. Some died, and they became rapidly sick. Okay, and when they died, when they sacrificed them, they looked at the lungs, and their lungs were just covered with virus and destruction in their lungs. This group was protected, where the source was protected. Okay, these, only 1 of the 8 even got sick, and that was a mild illness, and it was delayed by several days. So it took longer. So they basically, they got a smaller dose, which took longer to grow up and make them sick, allowing their immunity to grow and come back, so that it took care of their infection before it made them very sick. And when they sacrificed them, there was no evidence of illness in their lungs. Here, they put a mask on the receiving guinea pigs. 3 of 8 got sick, but only mildly, a delayed illness as well, and only mild changes in their lungs. So look, a mask on a person who's infected, even if they don't know it, protects everybody, a high level of protection. And even if you get sick from them, you're probably not going to die. So if you're around masked people all the time, you are really protected. If you are around unmasked people, if you just have a mask on, you know, you are going to be protected from dying almost certainly, okay? And if both happen, if everybody's masked, this thing goes away. Now look, don't be afraid of masking. Look, this can be fun. I know at SMU, the SMU bookstores already got masks with Mustangs written all over them. And the kids are competing with how they can mask. And SMU is going to try to open up with students on campus, but everybody's going to be masked. It's going to be compulsory. But there's a competition among the students already. All right, now look, here is your slide for the day. Here are the things that I think you should do. If you build these into your plan, after we've gotten the epidemic down, if you build these into your plan, you keep everybody safe. Okay, and I think there's a way that we can practice our art and do that. But I'm depending on you to be creative. So here we go. First of all, we've got to reduce the spread in the community. Don't start doing anything until this happens, but I think we may be a month away from this date. Okay, I'm optimistic, but I think that's maybe true. Most important is physical distancing. There's a study that just came out last week also that reviewed 172 other studies that have been done on this question. And they found that 3 feet reduces the infections by 82%. Just 3 feet distancing if you do nothing else. If you do 6 feet, it's 85. It's not a lot more, but it's a little bit more, okay? If everyone is wearing a mask, and then masking is the second most important thing. The same study found that if everybody's wearing just a cotton mask, you reduce the risk by 70%. If everybody's wearing a surgical mask, like you have in the hospital, the surgeons wear, 85% effective, not a lot more, but somewhat more. And if you have an N95 mask, this is the high-level mask we use in isolation if you're treating COVID patients in the ICU, it's 100% effective, okay? So if you're doing this and you get COVID, you probably got it at home from somebody that you didn't, that you weren't masking around. I mean, it's that good. Okay, so another way to prevent this, and may sound silly, but not speaking, laughing, shouting, singing, coughing, sneezing. If you don't do this, you're not going to expel the virus. If you're just sitting there in class and you're a student, and if the SMU professor is speaking to the students, and the students are sitting there not talking or maybe whispering only, they're not producing virus. And then if they've got a mask on, it's doubly good, see? And so the art forms that don't speak, like dance, for example, you are a very low risk to each other and to the audience, okay? Being outdoors is a big protection because the big outdoors dilutes the virus. And particularly if there's a breeze, it dilutes the virus and it goes away. And here, one of the pieces, there's a lot of evidence on this, but one of the most interesting things is, you remember there was a big political rally in Tulsa, indoors with no masks. And, Tulsa had a big epidemic after that, which is being traced to that event. But you remember just before that, there were all these Black Lives Matter demonstrations, all these major cities with thousands of people in the streets, but everybody was masked and it was outdoors. They've now done studies and there's no evidence that those people spread the virus to each other or to the city. That is amazing. So being outdoors is very forgiving. High ventilation. If you, in your theater or in your art venue, if you can jack up the air conditioning to where it feels a little bit drafty in there, that's good. What you want to avoid is a room with dead air, with poor ventilation. That is dangerous because this thing, when you cough, sneeze, or whatever, most of it is big droplets that drop to the floor, and if somebody's not within 3 to 6 feet of you, they're not going to get infected. But there are a few small, really tiny droplets that can go waft around the room and stay up in the air for a while. And if you got a poorly ventilated room, that's dangerous, okay? So talk to your air conditioning contractor, or if you've got an engineer, an HVAC engineer, talk to them. How much could you increase the ventilation rate, the fan on that? Could you retrofit that fan? I mean, you may want to invest in a bit higher ventilation system. I mean, it may be important to do this to stay open. If so, make it a little drafty in there. Make the patrons have to wear wraps to come to a summer concert. And that would be very helpful. Now you can also use ultraviolet light. These are blue lights that can shine, but the regular UV lights will damage your cornea and give you a skin rash. So you can't shine them on people. But in the hospitals, we have them shining up at the ceiling. And as the air circulates around the room, the viruses circulate up there and they get zapped. Okay, so it's called upper room ultraviolet lights. You can install those. You can even buy portable ones. You can plug in the wall and hang on the wall that shine up toward the ceiling and protect and reduce the risk of airborne spread. You can also put them in air conditioning ducts to zap the air as the air goes through. Now there's a new thing that will come out in the next year, probably a year from now. It's called far UV light. It's safe for humans, but it's even better at killing viruses in the air. You could put a bulb out there or a light bulb in the ceiling and illuminate the whole room with this far UV light. You can't see it, and it doesn't hurt people, but it'll zap stuff all over the room. So that will be a very great boon when we get it. Hand hygiene, of course, washing your hands frequently, not touching your face, not touching surfaces and so forth. Look, you don't have to wear gloves. I saw in some of the plans wearing gloves. You don't have to use gloves. In fact, we recommend not wearing gloves for this. It sounds paradoxical, but gloves don't help. You can contaminate them just the way you contaminate your hands, and then you've got gloves on, so you touch your eyes because I got gloves on. Or you're not careful, you get a false sense of security, see? So we don't recommend gloves. They don't help and they can hurt. And of course, testing and tracing, if you've got symptoms, you need to get tested and you need to give the names to the health department person who will call, give the names of the people that you were spent 10 or 15 minutes with at least without protection, okay? And then they'll call them, but they won't tell them where they got the name, but they will tell them to protect themselves. Just remember where we are now. Until we get this down, we're not in business. But as soon as this goes down and gets down to a low level, we ought to get going and have some art in Dallas. Okay, and that's it. So I'm going to leave this up and have some questions. And then let's say maybe in about 10 minutes, we can get to our examples. So
that sounds like a good plan. Thank you, Dr. Haley. Sure. So I have been watching the questions. There are a couple that I think will likely get covered with the case studies and our masterclass folks. So I might start with a few of the general ones and then just note some of the genre-specific questions before each of the case studies. There was a note from one of our attendees asking that, you know, you said both in your presentation that we might be wearing masks forever, but that if we wear masks for a month and are really good about distancing, we could essentially eradicate the virus. Can you talk about how both of those things could be true?
Yeah, because certainly there's some of the arts that we would like not to have masks, at least the performers. Now the audience, I think we're always going to, the audience is going to have to wear masks for the duration. I can't see any way around that. Even if they're distanced, and it may be that we can crowd more people in if they're wearing masks. That really remains to be determined and needs to be carefully considered. But certainly if they're distanced and wear masks, I think they would be fine, particularly if you can jack up the air conditioning or install UV lights at the top of the room or something. I think we could put a lot of people in an audience. The performers, certainly dance, I think they could eventually relax their masking because they're not talking, okay? Stage hands backstage, you know, our staff, we got to protect them. We got to protect our audience, our staff, and our performers. You've got three groups you have to protect, okay? So the performers, dancers, I think should wear masks initially, but they may be able to get by eventually. Singers, here's my thought. I've been thinking about this ever since we decided to do this. I think we can have opera. I think we can have theater without masks. Now, let me tell you, you tell some other public health people and they'll say, Haley's crazy. He's dangerous. But here's a way I think you can do it. I think, first of all, we've got to make sure our theaters have very, very good air conditioning with a high flow rate in the air conditioning. So I think our venues are going to have to re-engineer their air handling systems. Second, I think you could put in the wings a not too powerful fan that blows across the stage, that carries any kind of discharge out of the mouth, any kind of airborne virus, blows it off stage so that it then gets blown into an air intake. In other words, if we can have a cross current on the stage, however an engineer could do that, I really think it would be very safe because that, the performers, the love scenes are going to have to be a little bit more platonic. But I don't think you can have a kiss right there on the stage and sing right in somebody's face the way the great love scenes are done. But we'll just have to, the staging will have to be creative. But I think with proper air handling, I think, because see, that's just like being outdoors. If you've got a little bit of a draft going by, that's like being outdoors. And we know outdoors is relatively very safe. Another thing that we can do is, particularly in a few months, if these home strip tests work, like a pregnancy test, they're really advertising. I heard the advertisement this morning. They're advertising those to be so you could do one a day. They're going to try to get it down to $1 a test, so you could do $1 a day, and every performer would test themselves every morning. And I think if you did that, this thing is going to be very, very safe. And of course, hygiene, hand hygiene, and so forth, and the usual stuff. UV lights, you could put UV lights backstage to protect because these far UV lights a year from now, you won't be able to see them at all. So you could put a big bright far UV light backstage, and when you came off stage, there would be no virus in the air for sure. See, so. Okay, go ahead. Another question?
I think that's all really helpful. I know you just threw out some ideas that I hadn't even thought of.
I hadn't thought of them until a few days ago.
Well, I say that like I know anything about any of this. There's a couple of questions about like the heavy breathing and like sweating of dancers and other performers. If they did, if they were in close physical contact, how would you advise handling spread that could be because of those
first
things?
of all, sweating is of no concern. This virus comes out of your mouth and nose. Maybe if you have diarrhea at the other end, but it's mouth. It's mainly the mouth. It's mainly speaking, yelling, coughing, sneezing, etc. Okay, it's phonating. Because what happens is your larynx vibrates and spews out an aerosol, see? So if you whisper, your vocal cords aren't vibrating. And so it just air is coming out. And so you're not mixing particles in with it. So if a dancer is breathing hard, I don't think that's a problem, although I would like to see a cross current of air going by just to be sure. But as long as they're not speaking and yelling and singing, I think they're going to be relatively safe. Like children, they stand up to recite. I think they can recite. If you had a cross current coming across there, I don't think the audience is going to be affected because it'd be like outdoors. See, so to me that's the breakthrough idea, is that cross current of air, and then masking where possible. It could be that you have a line of children, they're all masked, and the one who recites, or when they have their line, they take their mask off and give their line, they put it back on. I mean, that would be something else you could do. The audience would be delighted the first few times they see it anyway.
There's another question related to that about wouldn't the increasing of movement of air indoors more quickly spread any contaminated
Well,
particles?
yeah, it depends on where the air goes. If the air goes right across the stage and you haven't, your engineers produced, see, an air source over one side and an air intake over the other, you know, air is a fluid. It's not gonna, it's gonna do that. It's gonna carry the stuff with it. So I think that would be very safe. And you know, and
Got it.
there are other ways to engineer our theaters. Again, you know, look, we may be in this for many years. We don't know if we can get rid of this thing. And if that's the case, we would like airflow coming from the audience up to the stage and then something going across the stage. So then nothing's coming out at the audience, but the audience air isn't coming to the performer because it's going off to the side, see? And
I might throw out one more question before we move to our masterclass folks. And I'm watching some of these and I'm hoping to incorporate some of them, or I'm assuming they might get incorporated in some of our folks. But do you think there's a way theaters can use amplification, or organizations, amplification or mics, to help minimize particles that come out when they sing or when people speak?
Obviously their voice is lower. They're not, pardon my phraseology, they're not shouting as loudly. But I'm not sure that's so important. I think if you have the air under control, I think you can sing. So I'm not sure about microphones. Now microphones, I think somebody's brought it up already, can be a little bit of a hazard in that, you know, with people getting close, if their lips touch it or they breathe on it and somebody else comes and puts their lips on it, that's not a good idea. So if everybody had their own mic, of course, or if somebody has a little hand wipe and wipes it off in between people, that would be okay. But okay.
Okay. And then maybe one last quick question. How long can the virus stay in the air?
Okay. They can stay in the air. Nobody really knows exactly, but from epidemiologic studies and from outbreaks, you know, the health department works up these outbreaks periodically. Most of them are related to bars, social events, family get-togethers. That's where most of our epidemics come from. All right, and what the conditions there are, you've got probably 1 or 2 people out of maybe 300 people crammed into a bar. You've got 1 or 2 people in that bar who are spreaders. See, of all the people who get this infection, even when they've got a lot of virus, most people are probably not spreading it. This is a concept called the super spreader. We know this from tuberculosis, measles, from all these contagious diseases. There are typically a few people who are super spreaders, and they can come into a room and just light it up and infect half or more of the people in the whole big room. Well, you know, they didn't go face to face with every person in that room. And so that's part of the epidemiologic evidence. Also, the guinea pig example is another one. There's something that goes through the air that goes more than 3 feet, okay, that infects people. So like, it's not as infectious as tuberculosis or measles, which can go hundreds of feet in the air and infect people. So it probably goes just 8 or 10 or 15 feet, but it could stay in the room probably an hour, I would say. But nobody really knows the answer. But it's got to be longer than just a few seconds or just a few minutes, but probably no longer than a couple of hours or so. Surfaces, it can live on shiny surfaces for 3 or 4 days. It can live on fabrics probably a day. Okay, so that gives you, it can live on a microphone a good while. So you need to, because that's a shiny surface, see? Okay.
That is super helpful. And I have to say, y'all, there's a lot of questions. So I think we might come up with some ways that we might get some answers and aggregate some of the similar questions
Yeah, let's
together
go
after the
to
session. But yeah, let's go on. I think Mara Richards-Bim from Cry Havoc Theater is ready to go with her reopening plan. So Mara, I think you're good to go. Please take it away.
Okay, so we were asked to put together what we would do when we reopen. So this is our protocols, our draft protocols for our production of endlings. For those who may not know, we're a youth theater company and we work with teenagers. So our rehearsal process would take place outdoors. And we would also limit students who we know are not socially distancing would not be allowed to participate. Upon arrival, everybody, students and staff, would sanitize their hands with alcohol sanitizers, have their temperatures taken. Anybody with a fever would be sent home and wouldn't be allowed to return until they'd been tested and tested negative. And then everyone would wear masks at all times during rehearsals. And I put, unless they're on stage, we are utilizing outdoors microphones, which we're gonna get into, I know, where people would speak at a microphone and then there would be movement, and whenever there was movement, they would have masks on. In terms of the production itself, it will take place outside. We're staging it. I love to hear that I was happy to hear that they only have to be 3 feet apart because we were going to stage it, 10 students always maintaining 6 feet apart. We do want to choreograph a movement sequence with them in full PPE gear, so there would be contact in that. When they are off stage, they're going to be asked to wear masks. We will have adults off stage in masks to ensure that they're doing that. Our big concern is, we have 2 big concerns, microphones. So not only do we have sort of regular microphones around the stage, we're also using a binaural microphone, which is sort of the centerpiece of the show. It creates 3D sound. And so all of the students at one time or another would be really up close to the microphone. It would be on a like a box where they would be sitting or laying or around the microphone. So that's one question we have about how dangerous that is and what we need to do to mitigate that. And then, in terms of the audience arriving, so it would take place outside. Everything would be, paperless. So tickets, programs, all of that would be ticketless. We'll have hand sanitizing stations provided. Staff will all be wearing masks. I was happy to hear they don't have to wear gloves, but everybody will be wearing masks. There'll be clear flow of direction of people in and out of the space. Again, it's outdoors, so we're less concerned in that regard. But the one thing that is a big challenge is that the audience would all wear headphones. So that's another question we have in terms of whether it's enough for us to spray the headphones down with, say, rubbing alcohol, if that's enough of a sanitizing in terms of passing it off from show to show. So those are, to me, I think the big touch points are the microphones, especially the binaural microphone, and then how we navigate the headphones for the audience. And that's all I got.
Okay. Listen, that's a really good, well thought out plan. Let me just make some comments. First of all, as you point out, being outdoors is very, very forgiving. So right away, you're way ahead of the game if you can perform outdoors. And 6 feet social distancing where you can do it is fine. But if the kids are, these are kids, right?
Yeah, they're high school students.
Yeah, if they're wearing masks, I think 3 feet would be fine. Now you may find some experts who would point out the CDC guidance is 6 feet, but I know some of the school districts are talking about that's one of the things, if their kids are masked, that they can relax the 6 feet to 3 feet, okay. Which will be important for school. So that's being discussed. So I think particularly if we've got the community spread down to low level, I would think that's fine. The stagehands are wearing gloves. I would definitely get rid of the gloves, not useful. Microphones, let's see, you said some kids may take off their masks to do certain.
They would take off their masks to be at the microphones.
Yes, that's
and so
that's fine.
Okay,
Yeah,
so even
fine,
if they're
because
using
you're outdoors.
Okay.
You're outdoors, so that's, and as long as everybody's social distancing, that's going to be fine.
So do we need to worry about any virus on the microphones themselves?
Okay. Now the microphones if they're not touching the microphone, it's perfectly fine. Now they may be talking and they may infect the microphone, but as long as the next person doesn't touch the microphone, see, the virus is not going to jump off the surface onto somebody. Okay. It has to be coughed there or light there from being in the air. It's not going to jump off of it. So, and just when between acts or whatever, somebody ought to go out and wipe it off just so it doesn't keep aggregating. And after the performance, you ought to wipe it off good. And I would use one of these sanitary wipes if you can. Those, they're hard to find sometimes, but we're starting to get more of them. So I think that would be very handy to keep a bunch of those around, although they probably would walk off. Okay. So yeah. In your write-up, you mentioned full PPE gear. I don't think you need any kind of personal protective equipment other than the mask. Face shields can be used, but if other people are wearing masks, I don't think that's necessary.
Okay.
So it'd be a little bit more. Now, your binaural microphone, what is that like? So
it's a fancy microphone that records 3D sound. So the idea,
so it's on a stand. Like,
well, it'll be sitting on a platform that people can sit next to it. It's got 2 ears, and
okay.
you talk into it as if it was a head.
Okay.
And so they would be especially close to it, and they'd all be sitting around on whatever surface it's on.
Are they going to be touching it?
They would not touch the microphone.
Okay, as long as they're not touching the microphone, it's irrelevant. But
the platform it's on, they shouldn't. What about
sitting? You don't have it on your bottom.
Okay.
Okay. So that's a no problem.
Okay.
So you just have to coach them not to touch the microphone.
Okay.
And, that's a considerable job, particularly for kids, but even for grown-ups.
Right.
There's a tendency to want to hold the mic.
Right.
So tell them, you have to teach them that and watch it. And if you see somebody make that mistake, you need to try to get them to correct it, and also coach them. No matter what they do, don't touch their face, don't touch their eyes or their nose or their mouth, because that's how you can inoculate yourself with it. Okay. And you don't need to wipe it down between students as long as they're not going to touch it. Now your audience, let's see.
The
audience wearing masks during the performance, absolutely. That's got to be everywhere. Even outdoors, they should do that. Alcohol, hand sanitizer is fine. And ethyl alcohol, just rubbing alcohol is just as good. That's is perfect. Gloves, get rid of the gloves. Let's see, your person flow in one direction, that's helpful. So that you had one other big thing. What was it?
It was the headphones for the audience.
Oh,
every audience member.
So does every person have just their own own?
So we're working through that, but we're trying to figure out the technology to allow them to use their own. But we are also exploring technology where they would be given a set of headphones that would be used in the show. And so the question becomes: how do we sanitize those? Can we just spray them down with rubbing alcohol? Do you have thoughts on that?
I mean, is one pair of headphones going to go around to a whole bunch of people?
It would be from show to show. So somebody would wear it one night and somebody else would wear it another night.
Okay. No. You can rub those down. Now, you check with the manufacturer to be sure the alcohol isn't going to ruin it. In the hospital disinfection world, that's something we always have to really check. Because alcohol or disinfectants can damage some kinds of equipment. And I'm not sure you need to spray it, actually. And how many days between shows?
It would be the next day.
Okay.
So it would be 24 hours. We are looking at doing. Yeah.
I would rub them down with a wipe.
Okay.
That's what, because if you're rubbing it, the parts you're going to rub are the parts that are going to touch people.
Mhm.
So I don't think you have to worry about a little crevice somewhere.
Okay.
So I think rubbing it down would be fine. I think spraying stuff on it might damage it.
Okay.
Okay, look, great plan, and I think that's doable, particularly being outdoors. That's a major benefit. Okay, let's go next.
Thanks, Mara. So we're going to go to Gail next, and I just want to note to everyone where we've had a lot of questions, so we're running a little behind. However, we are recording this. We're going to send out the recording, so if you have to jump off, know that we're going to send this around so y'all can use it for reference, because I know there have been a lot of questions about dance and singing. So Gail, are you ready?
Yes,
Oh.
can you hear me?
Yes, okay, we
Okay,
can hear you
great.
now, good.
Okay, terrific. So our dance company, Bruce Wood Dance, has 11 dancers and 2 artistic staff, so we have 13 people. Our plan was to go back to the studio. We have a big studio, 3,600 square feet, was to go back in 2 groups. So essentially we would have 8 people in the studio on one day and then 7 on another day. And we would alternate them Monday, Tuesday, Wednesday, Thursday. And we would do outside when possible, but for dance, we want to get inside. We were thinking we needed to only have 8 at a time so they could be 10 feet apart from each other because of the energy and definitely wearing masks. And we were worrying about, first, could there be any floor work? Could they actually go down on the floor and stretch as well? Or does everything have to be standing? And then traveling across the floor when you are taking dance class, does one person, how close? Usually there's an 8 counts between each groups, and the groups are usually about maybe 3 feet apart from each other. As they go across the floor, should one person actually go across the floor by themselves? And then when that person's done, then the next person, or could it be a little bit closer? So that's the whole thing with social distancing with dance. How 3 feet is 3 feet surrounding them in a circle of 3 feet? Would that be okay? Or does it have to be? We were thinking it had to be at least 6 feet, and it was being talked about being 10 feet. And then it would be that we called it the year of the solo. That dance ensembles we would only be able to rehearse a solo at a time, or a duet that was very distant apart so that they would not get together. But could we do partnering? That's another big question. If they're wearing masks and they're using hand sanitizer, could they touch each other? That's a big question in dance. Back to the studio, though, we were only going to the studio for 3.5 hours. We're usually in the studio for 5 hours. So we want to reduce mingling, reduce lunch, take lunch away so that the dancers will have that at home. Because we heard that you want to stay away from mingling to avoid close contact with each other. And then, of course, all the cleaning and disinfecting. And we put in UV lamps into the air conditioning ducts and have ionizers going. But the air conditioners, yeah, we'll crank them up because usually dance, you don't like it too cold. So that was a good thing to know. So basically, yeah, that's about it.
Okay, let me comment. Well, certainly if you can do this outdoors, you can take more license with other things. If it's indoors, then you got to be more careful. And by most of the time being outdoors and occasionally indoors, you kind of set up a situation where you're trained to do it outdoors, and now suddenly you got to do it indoors, and you might want to try to do it the same way. So that, I think that would be, you might want to have it so the same moves and everything can be done indoors and outdoors. Certainly, first of all, about on the floor, can people, yeah, people can get on the floor. There is some slight, small degree of contamination on the floor, you know, because if somebody coughs or or whatever, and they didn't have a mask on, there might be some viral particles on the floor, and if you did that and then touch your face, that you could infect yourself. That's a little far-fetched, though, so I wouldn't worry too much about being on the floor. Again, as they come off, hand sanitizer, you know, right away. Just have it automatic. When you come off into the wings, there's a hand sanitizer right there, and everybody uses it, or there's 10 of them, and everybody uses them. Okay. How close to pass? Okay, passing is not a problem really. You know, the social distancing is meant for people who are socializing, who are sitting there with each other for a period of time. And remember the CDC's advice about what is a contact. What is the contact of a person? Let's say person A is infected, and the person is exposed to person B, and you wonder, is B a contact? Well, the definition of a contact is somebody who's been within 6 feet for 10 minutes or more. Okay, so because you got to breathe a good bit, and they got to take in a bunch of virus, because if you just take in a tiny amount of virus, your body, anybody's body, no matter how susceptible you are, is going to extinguish that. Your body's good. In fact, it wouldn't even get down to your lungs. Most of it would precipitate in your nose or somewhere, and just the mucus and things would prevent them from infecting you. So you got to get a substantial dose to get really infected with any virus. And so now it's true, the research has not been done to define how many virus particles you need to get infected, but it's certainly more than 1 or 2 or a small number. So I wouldn't worry about passing close together. I wouldn't touch, but I think passing close is not a risk because it's instantaneous. You know, how close can you dance next to another person? I mean, there's no rule there. Again, if you're both masked, I would say 3 feet would be fine. 3 feet around you, so that you're a 3-foot circle, you know, 3-foot radius.
Yeah.
Can overlap with somebody else's 3-foot radius, but not their body. Okay?
Yes.
In other words, they could be like this. Well, anyway, you get the point.
But could they actually pick each other up?
Yeah, I think so. I mean, that's physical touching, and the only downside of that is their hands and arms and shoulders.
Yeah.
And I mean, all of that that potentially could be contaminated. But again, as long as they don't touch their face, as long as they've got a mask on and aren't touching their face, you know, and quickly get off, and as soon as they're off, use hand sanitizer. I don't see that as a big problem. You know, see, remember where this is a problem is if you're visiting your grandmother in the nursing home and she's lying there coughing, and you're in a little room and there's a poor ventilation, that's when you're going to get a fatal dose. See, that's the extreme we want to avoid. But a quick pass or picking somebody up, if you're both masked, there's no infection coming out.
Okay.
You know? So I think that's okay. Let's see. The studio 5-hour rehearsal or production, whatever. Again, ventilation determines how long.
Yeah.
If you've got good ventilation, which you do, and you've got UV lights, I'm amazed. That's wonderful. You've got UV lights in the air, in the ducts, and you have them out in the space.
They're in the ductwork. They're actually in the pipe, so they're not shining on people.
Yeah, in the ductwork.
Yeah.
You might really, I mean, everybody might look into for their venue. You know, there may be some federal grants coming down the way that we could use to outfit your space with upper room UV lights. And then in a year from now, when we get far UV lights, to put some bulbs so they shine everywhere. That would be I think that would be a huge engineering solution to a lot of the distancing and how long you're going to be there and so forth. And of course, you're going to clean your space too, and that's helpful and so forth. One thing you said that I thought was interesting, yeah, you can crank up the ventilation, but the dancers don't like it too cold.
Right.
Well, you need a good air conditioning engineer. They can regulate the temperature separate from the ventilation rate. Okay, so you need to challenge your engineer and say, look, I want my temperature to be 78 degrees, but I want 12 air changes per hour. You know, that is the currency or the nomenclature for how you quantify air ventilation. It's the number of air changes per hour. How many times is all the air in that room replaced in an hour's time? And in a hospital, which I used to be involved in designing these systems for protection, for ventilation systems for infectious disease units, we would want to have at least 12 air exchanges per hour. Now that's a lot. I mean, you can feel the breeze, but that's in a isolation unit with somebody with deadly diseases. So it tells you you don't need to be that much, but just whatever you have now, you know, try to make it more than that and get some good engineering advice.
Okay, thank you.
Yeah. Okay, great plan.
Thank you. Thank you.
Yeah, I think you can pull that off. All right.
Thank you, Gail. Thank you, Dr. Haley. Okay, we have our last person, Megan Heber from Children's Chorus of Greater Dallas, which I know folks are going to want to hear from because there's lots of singing related questions, just like dance in the Q&A. So Megan, take it away.
Thank you, Maura. Yeah, we're a little bit of the problem child. We have both the singing challenge and then the very large groups of children in one room together. So I'm going to run through our plan, but basically the point for me was, does this plan and thought process correlate with the recommendations, and is it feasible so far of how the research is looking? So to give everybody a little bit of background, this is about our flagship program, the Chorus program. We meet and rehearse every Monday night of the school year and perform 3 times at the Meyerson Symphony Center, once in the fall and then twice in the spring. We have 6 choruses with about 75 singers in each, and this is grades 4 through 12. So young ones all the way up to high school seniors. In addition to the singers, each chorus has 4 artistic staff members and approximately 6 volunteer chorus monitors who are parents. So this brings the grand total of people in each room for the choruses up to about 85. We rehearse at Lovers Lane United Methodist Church, and due to its large facilities, every chorus is in a separate room. Rehearsal start and end times are currently staggered by about 15 to 30 minutes. Singers do travel from all over the Metroplex to participate in the choruses, so they're coming from 48 different communities, from as far north as Gunter to as far south as Waxahachie. So of course, different counties, different regulations, all those different kind of considerations. And then a few other differentiating considerations in our COVID planning was we don't own our rehearsal space, so we're really dependent on Lovers Lane for access and then also making our space accommodations. And since our singers come from so many geographical locations, that the idea of community isolation, so keeping, for example, some of the school plans, keeping those small groups isolated becomes a little bit more challenging for us. We've decided to take a 60-day out approach to our decision making so that we can have some time to communicate to stakeholders and figure out exactly what the plans for the programs are going to do. Since we're 60 days out from September, we just made that first decision and that first call, which is to do online programs for the fall. With the research we were looking at and the decision matrix that I'm going to pull up for everybody in a second, it just didn't seem safe to us, for our singers, our families, or our staff to get everybody into the same location as we normally function. So let me real quick share my screen so when I'm talking about this, all of you can see it. So we decided to kind of take it from a 3-option perspective is, do we do the programs online? Do we do a hybrid of online and in person? Or do we, of course, go back to our normal programming of being in person? A crucial part of this decision matrix for us was determining the checklist. And this, of course, I would love some guidance on of what it should be, what we should determine that makes it safe to sing. For now, in guidance with one of our doctors on the board, we had determined that safe to sing means the mask mandate is lifted, Lover's Lane is open for business because obviously we can't rehearse if they're not allowing people in, and then also Dallas ISD being back into school. As of last Friday, like I mentioned, we made the determination, since we're 60 days out, to go into an online program for the spring, for the fall, with a determination about the spring to be done in November. So that's kind of our plan so far, and I would appreciate any feedback or guidance that you have.
Okay, so let's see. So what are the ages of your kids?
4th through 12th grade.
So you've got them all, 4th through 12th. Well, this is near and dear to my heart because when I was in high school, I sang in the Sunset Concert Choir for 3 years. I was a 3-year letterman. And Mrs. Stuckey's choir, it was quite, and Bill White's choir. Okay, so so you're going to delay all personal in-person performing and rehearsing. It's all going to be. How are you going to do online performing? I mean, how do you get it to where people can synchronize well across the internet? I noticed that Zoom doesn't have much of a delay at all, if any.
Yeah, Zoom gets a little funny when you add a lot of people for that. That time delay adds up. Yeah. Right now, we're going to use a combination of Zoom and then Google Classrooms. We're choosing repertoire too that we've done in the past and that we have archival performances of. So even if we're not able to mitigate the live performance together, we can still have the singers perform together with those archival performances. So we're working out the details now, but yeah, we just thought with the current climate the way it is, and with the large numbers, and then all this research about the dangers of singing, that at least for the fall, it would be better to shift online, and then make, of course, the determination for spring a little bit later as we get more information.
Yeah, I think that's good. Now, first of all, let me point out that, and I'm sure your physicians have pointed this out, that 10 and below are much less of a risk. And I mentioned the ACE2 receptor, you know, the kids under 2 appear to have fewer of those, so they're not as susceptible to the disease. But that doesn't mean they can't get it. And there's this delayed inflammatory syndrome that you don't want to have, although it's quite curable and has no long-term consequences that we know of yet anyway. We still would not like to get them infected. The high school kids, though, are probably much more like adults and can get it and spread it much more. So that's a problem. So, and I think it's wise for you all, particularly with the kids, where they're going to be harder to manage with so many, that to put it off until there's a lot more experience with this. So obviously, as long as they're at home and distance, there's really nothing else to talk about for that. But how far have you gotten in your plan to bring them together after the fall, say next winter or in the following year? I mean, we may still be dealing with this if the vaccine doesn't come through. So, yeah,
we've put together budgets and scenarios if we have to remain online for the entire year. So right now we're definitely looking at and planning for fall and spring, probably being online to be based on how things progress from here. And then we've started mapping out, some of the national organizations for singing has put out some really great guidelines about masking and distancing and what you could do in rehearsal scenarios. And the one that seems most feasible right now is doing some sort of hybrid version if this goes on for more than those 2 semesters. So bringing in small groups of children at a time while simultaneously casting the rehearsals to the people who are still at home, and then kind of rotating that. So it's always the same group of students who are coming in together, and kind of, again, that approach of limiting multiple interactions with different groups of students.
You know, I would really encourage you to bring up to your medical board, and you're really wise to have some medical advisors who can really advise, particularly for the children, and talk to them about the ventilation idea. Also about being outdoors in the parts of the year that are temperate where you could do that. I really think you could get them together and eventually, particularly when the community spread is way down, I think you could get them together if you can solve the ventilation piece, and because that's, I mean, it's like outdoors. Think of all those demonstrators, Black Lives Matter demonstrators, all out there shouting and yelling and exercising and panting, but they were masked and they were outdoors. And outdoors, all that means is there's ventilation, and the virus is being carried away and being diluted out in the air. Well, you can do that indoors too. It just takes a clever engineer. Now, Lover's Lane Methodist is going to want to bring a congregation back there eventually. And so they need this advice too. As far as I know, nobody's talking to churches yet, but this needs to be talked about, that ventilation needs to be there, and we're going to need that into the future. This may not go away. So, or after COVID, there may be another one coming from China. We never know. Okay, any other questions about yours?
No, that you answered it. Thank you very much.
Good. Okay, excellent. All right. Oh, you're muted.
There, I knew I was going to do it at some point.
Yeah.
So I want to thank you so much, Dr. Haley, and tell you that we still have a variety of questions that I might circle back with you about in the next couple days and see what your thoughts are. But we really appreciate your time and expertise. I know that I want to remind everyone, we did record today's session. We are going to send it out, so you guys can refer back, and we are going to work on how could we look at some of these additional questions that we don't have time to answer, but how can we work to get you the answers that you need. But really, I know you can't hear everybody, but I want to applaud on behalf of everyone for your time. And we will follow up with everyone, but thank you to Dr. Haley, our panelists, and thank you to everyone for taking the time to join us.
Well, good. Well, I just hope this has spurred people's creativity to give you some ideas of how you might re-engineer your product so that that you can get back into business, because I've got to go see an opera as soon as possible.
Ditto, I think, from everybody. Thank you so much, Dr. Haley, and thank you, everyone. Have a fantastic afternoon.
Very good.